Sorry, just one moment. Here. All right. Sorry about that. And Caleb, it is all you. Thank you so much.
Awesome. Thank you guys so much. All right, hi, everyone. Good afternoon. For those of you that don't know me, my name is Caleb. I'm a fourth year at Ross. And today I have the privilege of presenting on cardiac allograft rejection. This is a case that combined both cellular and antibody mediated injury. Um, so, yeah, without further ado. So at this time, I'd like to go ahead and introduce Dr. Ladea. She's a PGY3 IM resident at Cleveland Clinic, Florida. She graduated from Ross in 2023, and I had the privilege of working this case with her last year. So for our guy that came in, the chief complaint, he was feeling short of breath with activity and having some dizziness. Obviously, this is incredibly vague, a lot of possible etiologies that we could be dealing with a complaint like this. But yeah. So a little bit about the HPI. This was a 49-year-old male with a history of non-ischemic cardiomyopathy. He had a heart transplant in March of 2024, presenting with 1 month of progressive dyspnea on exertion, some orthopnea, dizziness, palpitations, and some bilateral lower extremity edema. He also reported some decreased urine output, denied any chest pain, fever, or recent illness. Um, for him, the only thing to focus on, he had some chest pain or denied any chest pain. We'll get into that a little later as to why. Um, but past medical history for him, like I said, this non-ischemic cardiomyopathy. He actually had an idiopathic dilated cardiomyopathy, underwent the heart transplant in March of 2024. His home immunosuppression regimen was tacrolimus 3 milligrams BID and mycophenolate 250 milligrams BID. Some other history for him, he had hypertension, hyperlipidemia, some type 2 diabetes, chronic kidney disease, and SVT. So next we'll go into some of the vitals, physical exam, and labs. Um, anyone, like before we get there, anyone have any ideas, any labs you'd like to order or that you'd be interested in? So for these vital signs, he was hypertensive, BP 148 over 110. He was tachycardic at 122, afebrile, no respiratory distress, satting well. On exam for him, he did have some notable JVD. He had some pitting edema bilaterally. He was in normal sinus rhythm, and he had 2+ radial pulses as well as 2+ PT and DP pulses. Labs significant for him. He had a BUN of 36, creatinine of 2, his baseline of 1.15, AST 72, ALT 155. BMP was 4,373. Troponins were elevated but flat at 21, 22, and 17. Procal of 0.09, and an AlloSure of 5.1%. This was from 0.61 in January of 2025. And AlloSure, just for those of you that don't know, is donor-derived cell-free DNA. So it's a marker we can use to look at possible graft dysfunction. So imaging for him, I included 2 X-rays. This one on the left is from September 2024, so this is just a couple months after his transplant, and then this one in June 2025 was on admission. So for that, you can definitely see some cardiomegaly has developed. He's got a little bit of vascular congestion, but nothing too crazy. But just wanted to highlight the cardiomegaly that he's developed just over a year from transplant. We got an echo on him on admission. It showed this acute new drop in EF of 30%. A one from a couple months ago in March was at 62%. Showed 2+ mitral regurgitation and 2+ tricuspid regurgitation. It also showed a large anterior pericardial effusion. So our assessment for this guy. So again, this is a 49-year-old male with some non-ischemic cardiomyopathy, had a heart transplant just over a year ago, presenting with 1 month of progressive dyspnea on exertion, orthopnea, lower extremity edema, and some decreased urine output. We have some new systolic dysfunction, an acute drop in EF to 30% from a prior of 62%. He has an elevated BNP of 4,300. We have an AKI, as well as some transaminitis. Clinically, we have evidence of volume overload, as well as some end organ dysfunction, so suspicious for cardiogenic shock. And again, we have that elevated AlloSure, suggesting some acute graft injury. So our plan for this gentleman, cardio actually saw him right before we did. I was part of the ICU team at this time. We started him on milrinone 0.25 for some inotropic support, as well as some vasodilatory properties, reducing afterload. The same day he came in, we underwent right heart cath. They did an endomyocardial biopsy. They left a swan in place just for some hemodynamic monitoring, given kind of his volatile situation. We continued with this tacrolimus, 3 milligrams BID, however, increased his mycophenolate up to 1,500 milligrams BID. Started him on some methylprednisolone, 1 gram daily for 3 days, given the acute rejection. We started him on nitroprusside drip to reduce afterload. Our target SVR was between 900 and 1,200. We subsequently switched that to hydralazine and isosorbide, given kind of the side effects with cyanide and with prolonged nitroprusside drip. So we switched to that for reduction in preload and afterload. We also started him on some IV Lasix, 40 milligrams BID for diuresis. So again, just more of his course. That endomyocardial biopsy that we did demonstrated this 2R acute cellular rejection with some antibody-mediated rejection as well. So for that, we started him on anti-thymocyte globulin, 1 mg per kg for T-cell suppression. He was initially planned for 3 doses of that, but after 2, he had an absolute lymphocyte count of 0, so we held the 3rd one. A repeat echo for him showed an EF mildly improved up to 35%. At that point, we chose to undergo 5 sessions of plasmapheresis. This is so we could take out those donor-specific antibodies that were contributing to this acute rejection. They did another endomyocardial biopsy about a week later. This continued to show 2R rejection. So we decided to go with that additional anti-thymocyte globulin session, as well as repeat that 3-day high-dose steroid course. A subsequent echo after that showed EF improvement up to 50%. That allowed us to wean the milrinone, which he tolerated well. And they did a final right heart cath prior to discharge, with another biopsy that demonstrated 1R rejection, as well as an improving clinical picture. So we were able to discharge him home on an increased dose of tacrolimus to 5 milligrams BID, mycophenolate 1,500 BID, as well as prednisone 5 daily. Since then, I was able to kind of see his course. He's been following up with cardio and doing well since discharge. So cool to see the improvement there. These are just some of the right heart caths that we did during his admission, just so you could see the numbers. So on that initial one, right atrial pressure was elevated at 11, right ventricular pressure 35/10, pulmonary artery pressure elevated. His wedge was 20, a decreased cardiac output and cardiac index at 3.2 and 1.5, and an SVR of almost 2,500. So some a significant drop in his hemodynamic parameters. These are the other subsequent ones where you can see really improvement. Right atrial pressure was down to 2 a week later. Right ventricular pressure is 25/2. Pulmonary artery 26/10. Improvement in cardiac output up to 5.3, as well as the index up to 2.3. And then finally, prior to discharge, just some further improvement in those numbers. SVR dropped all the way back down to 1,500. So did really well with the interventions that we were able to provide. All right, so that was his kind of clinical course. Next, I kind of wanted to go over a little bit of the overview of transplant rejection, some of the pathophysiology and other management topics. So for this is from the ISHLT, which is the International Society for Heart and Lung Transplant. They're kind of the governing body when it comes to management strategies, as well as classification of rejection, which is what this diagram is showing. So on the top, it's talking about the acute cellular rejection side of things. We have grades 0, 1R, 2R, and 3R. Um, and that really is dependent on the biopsy itself, how many foci of damage that you see in the biopsy that you take. So again, he was in the 2R, in the moderate severity category. And the ISHLT recommends 2R or above is going to require, some inpatient treatment with some of those therapies that we've already talked about. On the lower side of the diagram, you can see this is the antibody mediated side. And this is really divided into histology and immunopathologic staining are the two categories that they use to look at the extent of antibody involvement. I couldn't find his exact grading, but they just commented on it that it was a combined case with evidence of antibody mediated rejection. So a little bit about the epidemiology. In 2023, over 5,000 were actually performed, but the vast majority of those being performed in the US with a total of 4,600. The rates of heart transplant rejection from discharge through 1 year have dropped from 30.5%. That was from 2000 to 2004 to 24.1%. That was 2010 to 2014. And this is due to the advancement in immunosuppressive therapy that we currently have. The one thing I wanted to talk about is something called CAV, or cardiac allograft vasculopathy. This patient didn't actually have this, but it is the number one cause of mortality in patients in the long term. It's there at 17% after 3 years for these patients. The leading cause of death in the first year is actually infection in the setting of immunosuppression. That can actually be a cause of death for up to 30% of patients post-transplant. And combined cellular and antibody mediated has been seen in up to about a quarter of cases. So pretty cool to be able to talk about today. So the pathophysiology of the acute cellular rejection, not to go crazy deep on like an immunology lecture on you guys, but this is the recipient T lymphocytes recognize these HLA antigens through both direct and indirect antigen presentation, which you can see in the top right diagram there. Obviously, we try to match those as well as possible anytime we're undergoing transplant, but very difficult to get any 100% match. This is obviously mediated by CD8 and CD4 T lymphocytes, with the CD8 lymphocytes causing direct cytotoxic damage to the myocytes, and CD4 being the prime player with release of further inflammatory cytokines. The main players with those being IL-2, IFN gamma, and TNF alpha, which cause further inflammatory cells to come to the site with further graft dysfunction. Again, this inflammatory infiltrate leads to direct myocyte damage and the subsequent graft dysfunction that we see. So the pathophys of the antibody-mediated rejection, this is obviously primarily mediated by B cell activation that leads to the production of these donor-specific antibodies. These antibodies then bind to antigens present on endothelial cells, inducing the complement cascade, causing complement deposition into the vascular endothelium. This causes further damage, capillary inflammation, and it can actually cause microvascular thrombosis. So looking at both the acute cellular mediated and the antibody mediated, you can see that when they're superimposed on one another, you have two different pathways of graft injury, with cellular causing direct myocyte damage, as well as the antibody can give an ischemic component as well, causing even further myocyte damage. So when they're superimposed on one another, it's a worse prognosis for patients due to the two separate pathways that this is mediated by. And then this cardiac allograft vasculopathy. Again, this patient wasn't suffering from this at the time, but given that it's the number one cause of mortality in these post-transplant patients long term, I wanted to talk about it. So it's this panarterial process driven by immune-mediated inflammation that causes intimal hyperplasia in the entire artery. So not like atherosclerosis, where we can have kind of spot lesions with plaque buildup. This causes a full luminal stenosis, which can result in myocardial ischemia, further contributing to graft dysfunction. The reason this is um, such a severe problem for these post-transplant patients is this really isn't amenable to stent placement because you're not able to actually do angioplasty if it's a plaque or an atherosclerotic lesion. This is a full luminal stenosis, so really not amenable to any intervention. The incidence steadily rises post-transplant every single year. At 10 years post-transplant, it's at 50%. It'll affect half of these transplant patients and is the number one kind of comorbidity to be on the lookout for. Yeah, so management strategies, like we talked about, the ISHLT is kind of the governing body when it comes to these overarching themes. But ultimately, there's a lot of medical center and hospital specific strategies. So a lot of it can actually be dependent on the cardiology attendings and fellows that may have had previous experiences with cases like this, what they found to work. Again, there's some overarching themes, but it can kind of be tailored to personal experience and what people have found works. For this acute cellular rejection, high dose steroids, like we talked about, that 1 gram of methylprednisolone for 3 to 5 days is standard. The antithymocyte globulin is fairly standard. Inotropes for evidence of cardiogenic shock when you have end organ dysfunction are obviously a pillar of therapy, and increasing the anti rejection meds. The ISHLT has referenced in different studies tacrolimus as far as calcineurin inhibitors has proven to be superior. So you'll often see tacrolimus used for that reason. Guidelines for treating the antibody-mediated rejection include, again, these high-dose steroids, IVIG, and the PLEX therapies. For this patient, we ended up using the PLEX therapies, which in his case worked very well. The endomyocardial biopsy is still the gold standard for diagnostic tool for identification and classification of rejection. Obviously, it is an invasive procedure, so there's been movement away from that as far as a screening tool. It's now more of a once they're in an acute rejection episode for staging, and then to see how the therapies are helping the patient. So again, like this next point, the previous surveillance relied heavily on EMBs. The focus is now shifting to some more non-invasive, such as that donor-derived cell-free DNA, the AlloSure that we were talking about, as well as different imaging modalities, such as echoes that can look at acute drops in EF. They can look for wall motion abnormalities, different things like that, as well as cardiac MRIs. The cardiac allograft vasculopathy is the most concerning long-term complication. For that, the ISHLT recommends some coronary angiography, mainly in the first year, as well as intravascular ultrasound. They recommend these within the first 5 years post-transplant, but data after 5 years isn't necessarily as prevalent for is there benefit to after 5 years, but obviously the concern is the CAV that is the cause of mortality for a lot of these patients. The last thing I wanted to talk about was that so he denied chest pain, which is kind of interesting. So for these patients, what you have to keep in mind is post-transplant, they are undergoing surgery, which causes the laceration of nerves. The innervation is not quite the same. So these patients are actually not really typically able to feel chest pain like you might think, which is one of the reasons CAV is so serious, is because these patients will not present to the clinic with anginal type symptoms from this kind of ischemia. They won't show up saying, hey, when I walk, I get this chest tightness and this chest pressure, and then when I stop, it goes away. So that's why this monitoring is so key, because they're really unable to feel those typical ischemic symptoms that we would associate with this luminal stenosis. So that's why these screening mechanisms are so important. But yeah, the reason I wanted to talk about this was, for those of us that want to go into internal medicine, this acute decompensated heart failure or acute on chronic is very prevalent. I've seen it, I don't know how many times in the ED and on our IM service. But when I first saw this patient, I was never expecting this to kind of be all the etiology and the things going on behind it. So definitely always important to keep an open mind and understanding that there's numerous pathophysiologies is the way patients can present with this kind of acute decompensated heart failure picture. But yeah, those are my references. And then I just want to say thank you guys. Really appreciated getting the time to talk about this topic. At this time, if Dr. Ladea is still here, if she has anything she'd love to chime in on about this case or any clinical knowledge, we'd love to hear from you.
Hi, yes, thank you. Can you hear me?
Yes.
Okay, great. Excellent presentation, Caleb. It's always a pleasure working with you. And we're fortunate enough to be able to care for these patients, mainly in the medical ICU, because oftentimes they do require inotropic support. From the research associated with rejection in transplant patients, it looks like antibody mediated is the most common and the leading cause for heart failure and rejection. But we don't often see both mixed cellular and antibody mediated rejection. So I think there isn't a lot of data as of yet. It looks like a lot of studies are done from the 2010s and some more recently in the early 2020s. But it's definitely interesting to see that this patient had to receive both the anti-thymocyte for the cellular rejection and then the Plex for the antibody mediated. This increases, unfortunately, the mortality within 5 years for the patient. So, as you were, I think, emphasizes it's important to treat it, catch it as early as possible. And these patients have, I believe, biannual endomyocardial biopsies to screen for this. So the cardiology department is definitely on top of it, but it still happens, unfortunately. So, and another thing to keep in mind is while patients are receiving the anti-thymocytes, they are completely immunosuppressed. So we often have to follow very strict protocols to, avoid them catching a bug while they're here in the hospital with us. So that's all I have. And thank you so much for having me.
Thank you, Dr. Ladea.
Yes, thank you, Dr. Lydia, for coming and being a part of this journal club today too. We really appreciate it. Does anyone have any questions? I will say, Caleb, you were really thorough and with all the patho and everything like that because it was really interesting. I really appreciate your time today, Caleb.
Yep. Thank you guys so much.
If yeah, thank you, Dr. Ladea. Again, thank you for your time today as well. For the rest of our members, we'll be just going through our normal journal club meeting stuff with CRG. Thank you.